How's it going, guys? So it is 7:35 p.m. Tuesday, April 26th here in Japan. It is pouring rain outside right now, so I apologize if my mic is picking that up. I'm not sure if it is, but the alternative is don't make a fucking clip, right? So, I mean, I'll attempt to have a semblance of productivity right now. So how about prefacing longer than I already have? Why don't I start the fucking clip? How does that sound? So before we get started, please subscribe to my channel. I really appreciate it. Give the video a like. Really appreciate it. Find me on Instagram at Mehlman_medical. Mehlman_medical. Link is down below. Find me on Telegram. Recently created Telegram group and channel. Links are down below. Now let's start the clip. 32-year-old woman. She has a 2-week history of left-sided flank pain and blood in the urine. No significant past medical history. Vitals are within normal limits. A CT of the abdomen shows multiple cysts within the left and right kidneys. Serum studies show mildly increased creatinine and urea nitrogen. Genetic screening confirms a mutation in the ADPKD1 gene on chromosome 16. Question wants to know the most appropriate next step of management. So clearly we have autosomal dominant polycystic kidney disease. This is going to be the type that shows up in adulthood, 30s or 40s. If they give you autosomal recessive PKD, that's going to be pediatrics, often associated with hepatic fibrosis. So what are we going to do next for ADPKD? Let's just walk through the answer choices here. Choices A and B, dimer-captosuccinic acid renal scan and intravenous pyelogram, respectively. Wrong fucking answers, okay? I have never once seen either of these as a correct answer on any NBME exam for step 1 or for step 2, okay? So if somebody in the future, one of you watching this clip, encounters one of these as a correct answer on assessment, I'm not talking about Qbank horseshit, okay? I'm talking about actual NBME USMLE material. If you encounter one of these as a correct answer, by all means, let me know, okay? And I'll be like, wow, never seen those correct before. Okay, when students don't know an answer, they tend to choose weird-sounding shit, all right? So these can theoretically be done to visualize the anatomy of the kidney, okay? Choice C, MRI, angiogram, circle of Willis, wrong answer, albeit very tempting, right? So many of you probably thought that this was the answer, all right? Because you've heard that autosomal dominant polycystic kidney disease and Ehlers-Danlos syndrome can cause circle of Willis Berry/saccular aneurysms of the anterior communicating and posterior communicating arteries, which can cause subarachnoid hemorrhage. So you might think, oh, we'll do like MRI, angiogram, circle of Willis. This actually is the wrong answer. It's not indicated unless a patient specifically has a parent who's had a subarachnoid hemorrhage in the setting of polycystic kidney disease, okay? And the reason that you might, even if we want to make population health arguments in favor of it, it's not as favorable as, which our correct answer is, serial blood pressure checks. Now, the cysts, as they enlarge over time, will impinge on the microvasculature of the kidney, causing a surge of RAS, renin-angiotensin system, which will cause blood pressure to increase. So patients with polycystic kidneys often have extremely high blood pressure, okay? Blood pressure is a significant cause of morbidity in these patients. So they can often die from renal failure, or they can die from complications of hypertension, not necessarily subarachnoid hemorrhage, even though they can get cysts, okay? You should also know that the most common extra-renal location for cysts is the liver, okay? Avoiding cystourethrogram, retrograde cystourethrogram, wrong answers, but high yield for 2CK. Retrograde cystourethrogram is going to be performed for bladder injury. If they want urethral injury, they'll just have retrograde urethrogram alone, not the cysto part, okay? Avoiding cystourethrogram, this is done for posterior urethral valves. It's the most common genitourinary abnormality in neonatal males, okay? A 12-hour-old male who has suprapubic mass, which is the bladder, okay? So it can occur in a neonate. It can also, there's differing severities of posterior urethral valves. It can also occur in a young boy who's had recurrent urinary tract infections or pyelonephritis, okay? So your take home for this question is, for polycystic kidneys, you're going to do serial blood pressure checks, MRI, angiogram, circle of Willis, wrong fucking answer. You know the deal. I'm going to continue to make more content. If you like my stuff, subscribe to my channel, and I appreciate your time. That's it.